Hello, everyone. Welcome to the webinar, Health Literacy Considerations for Cancer Prevention Initiatives with Older Adults, supported by the GSA Innovation Fund, the Generativity Effect. The webinar is being recorded and will be posted on the GSA website. A notice to all attendees will be distributed once the recording is available. A question and answer session will immediately follow the live presentation, and we will be accepting questions through the questions feature accessible on the GoToWebinar panel. Also located there is a downloadable copy of the presentation slides. So the presentation today will be given by Dr. Rima Rudd, Senior Lecturer on Health Literacy, Education, and Policy in the Department of Social and Behavioral Sciences at the Harvard T.H. Chan School of Public Health. Thank you, Rima, for bringing us this important program.
Well, I'm delighted to be here, and especially to bring a health literacy perspective to cancer prevention initiatives for older adults. I just want to note very briefly at the beginning that this webinar is linked to the recent CDC-sponsored supplemental issue of the Gerontologist, volume 59. So I'd like to begin with a brief focus on issues faced by older adults. The most difficult challenge for older adults is that while literacy skills tend to decrease over disuse and over time and age, the demand for such skills increases for health activities, partly due, of course, to the complexity of health-related tasks and to the formidable tasks involved in navigating our healthcare institutions and systems. There are special challenges for older adults that relate to age-related changes, such as a decline in literacy practices, which from the education perspective leads to more limited literacy skills. There's also a decline in general and cognitive abilities, which also impact literacy skills. There are also developmental issues and psychosocial issues. There are concerns about this that focus on a sense of agency. Can you, over time, as effectively advocate for yourself? Memory issues, unrealistic expectations, taboo subjects, as well as social norms, such as bias, that make open conversations and open communication a little bit problematic. Now, with cancer prevention, there are some special challenges involved here as well. With the issue of preventive care, I just want to begin by noting a particular study, Feinberg's analysis of literacy-related data, does indicate that older adults with stronger literacy skills are much more likely to engage in preventive care. And this goes along with a decade or so of findings from health literacy studies that literacy skills are indeed related to a variety of health outcomes in health promotion in general, disease prevention more specifically, and in the management of chronic disease. So this, of course, is true for older adults, and we need to keep this in mind. There are also some literacy issues related to cancer prevention itself. Research, over 2,000 articles, mind you, indicates that across all health topics, the literacy level of health information in print or online far exceeds the documented skills of the public. In addition, we've long known that cancer itself is a topic that elicits fear, and fear affects cognition. Furthermore, from a literacy perspective, we know that abstract concepts are more difficult to grasp than our concrete terms. And we must keep in mind that prevention really is much more abstract than treatment. Treatment can be measured, monitored, seen, talked about, while prevention remains much more vague to many people. So what is our challenge? Studies of doctors' communication skills, the needs of elderly patients, available cancer information has indicated that cancer communications overall have not met the documented needs of the public, or of older adults in particular? Can we do better in this new cancer prevention effort? Let's turn to some health literacy insights and guidelines that could indeed support our effort. I'd like to begin by talking about health literacy. So I begin with a definition of terms, really. Up until recently, we focused on the skills of individuals. And more recently, we're now focusing on the broader context of health literacy, not just the skills of individuals, but the skills of professionals as well. We need to take into account the multiple texts that we develop so that people can access information. And from an educator's perspective, texts include talk as well as writings, as well as postings. Something that we've not often considered are the tasks that are involved. And we need to consider both the tasks that are involved with using the text, with listening, with reading. And we have to consider the more distal tasks that are related to the actions that we need to take after reading a text. So if, for example, we consider a text, a label on a medicine bottle, we have to figure out all of the items on that bottle, most specifically dosage, for example, and then we would consider the distal task as taking the medicine as indicated on the bottle. So 2 levels of tasks here. We need to consider the context as well. And context here relates to the emotional and physical issues that one may come to a health-related activity with, perhaps fear, perhaps fever, perhaps worry. But we also need to consider the broader context of our institutions, the institutional norms, the structural issues, the facilitators, and the barriers that are present in our institutions. Finally, then, for a definition of terms, we need to note that health literacy actually resides in this middle section where all of these important key variables, skills, texts, tasks, and context interact. Keeping that in mind then, what I'm going to do now is talk about each of these individually. So let's turn first to the skills of older adults. We know from national and international surveys that adults in general have more literacy skills than we once envisioned. However, we also note from these studies that the skills of older adults are more limited than those of working adults. So we have the findings from the 1992 National Assessment of Literacy Skills. We have the findings from the 2003 National Assessment of Adult Literacy. We have the findings from the 2003 Halls analysis. And we have the findings from the most recent 2011 Assessment of Literacy Skills. Now, these assessments, by the way, have been done in all of the industrialized nations, and we see similarities. Overall, older adults have more limited literacy skills in relation to reading, as well as math, as well as use of technology, than do working adults. Turning next to some of the difficulties faced, in the United States, about 15 million adults ages 55 to 75 have lower literacy skills. That means that they're going to face difficulties obtaining basic health information and using that health information. They're going to face difficulties navigating the healthcare system, sharing personal information. For example, it's very difficult to describe to someone who's a relative stranger, like a doctor who you only see periodically, use it to find the words to explain a new feeling that you've had here, perhaps in the upper regions of your abdomen. You don't know exactly what's behind that. It's a new feeling. It's painful. You have to find words to describe that pain. That requires very sophisticated literacy skills. Engaging in self-care and chronic disease management, understanding probability and risk. These are some of the difficulties faced by people who have limited literacy skills. Now, indeed, we have to take action. We have to help people increase and improve their skills. Now, we can support and increase adult education opportunities that are quite successful. Canada did this after its initial findings of adult literacy skills in 1993 and saw increases in skills in the next assessment of adult literacy skills. We have to support and increase patient education opportunities. We have to integrate patient-centered care, but there's a problem here because those of us who are in the health and public health fields are not literacy teachers. We have to indeed reduce demands. There are a number of findings from health literacy studies that really indicate what works when we take action to reduce demands, slowing the pace of talk, for example, providing summaries, adhering to plain language guidelines, using teachback, asking a patient or a participant in a program, did I leave something out? Is there something of importance that might help you? Or asking a patient, for example, help me see if I left something out and let me know how you're going to take your pills in the morning. And teachback is in contrast to testing. So we're not saying, do you understand, where people readily shake their heads yes because they don't want to appear faulty. But we need to take responsibility for our communication. Providing health education sessions, improving health materials, leveraging technological advantages. These are things that we can do. Now, we also, in doing all of this, we need to note and pay attention to the preferences that have come out of studies with older adults. Slower paced talk, accessible information with clear layout, design, and organization, aids such as note takers and navigators, adaptive technology. So we need to then build our skills as health professionals in our ability to do this. Few programs to date fully prepare health professionals to take action in these realms. There is scant time in many curricula, whether it be medical school or nursing school, and while a few institutions are indeed moving ahead in regard to helping people train better and improve their communication skills in speaking, in listening and providing feedback, in teaching, perhaps how to use a peak flow meter to understand when is a teachable moment, in writing, and in choosing appropriate materials. Now, we need to enhance our skills. We begin first by raising awareness. People need to know about the literacy skills of U.S. adults because we have some faulty assumptions that we need to challenge with the very clear recorded findings from the adult literacy skill assessments that have been done. We have to encourage a new kind of practice where we prep people before a meeting, where we pay attention to talk and turn taking, where we follow up with clear guidelines for people. We have to provide aids, we have to improve opportunities, and we can enhance skills by improving opportunities for people in professional preparations, licensing exams. We've long been told that if it's on the exam, institutions will teach to it. We have to provide continuing education programs for professionals, such as grand rounds and so forth. So in reducing demands, we also have to attend to institutional norms, practices, and policies. We have to look at the patient load. We have to look at support staff, time on task, preparation time, access to suitable materials. So we can't simply place the burden on the shoulders now of health professionals. We have to look to our institutions to make sure that they're bringing about change so that professionals can take needed action. One of the areas that we need to pay attention to are the health texts. Practitioners don't write the text that people are given. Now, text, again, using the educational definition, refers to talk as well as to print online and in writing on paper itself, to postings and so forth. Most health texts are difficult, dense, and complex, and we have well over 2,000 to 3,000 published studies that indicating that written materials far exceed the documented skills of the US public. We must differentiate here between available information and accessible information. So we have a wide multitude in various media of health information available for people. But that available information is not necessarily accessible, especially if it's poorly written, poorly organized, and does not help people gain the information that they need. Accessible information must be understandable and usable. We know that there are many, many tools and guidebooks available, freely available for people, but it's indicated that they're infrequently used because they're frequently cited in the development and design of materials. Next, I'd like to look at some of the issues, and there are multiple ones that we need to pay attention to with text. I'll give at the end some information about where one can find very good tools for assessing information and developing information. But here, I have a slide here that notes that we have to pay attention to vocabulary and jargon, as well as math concepts and tasks, words that we take for granted, such as risk and normal and range, that a majority of people have difficulty understanding. We have to pay attention to our organization, to sentence length, to layout and design. We have to pay attention to whether or not the main point is highlighted and that people have follow-up action that they need to take. And so the design of materials, the design of information is incredibly important. We have to clarify our information, looking at lessons learned. For example, we need to provide translations from scientific or medical jargon to the everyday words that people can grasp. Pay attention to the fact that our professional language is indeed a bit of a foreign language to many people who have not studied the way we have studied. We need to highlight main points, we need to summarize, we need to provide action steps, we need to do math for people. Some sample strategies with talk and writing: encourage someone's story, assume responsibility for our communication, check for clarity, apply plain language guidelines. These and more are strategies that are indicated in, again, the easily available guidelines for developing health information that people can use. We do have to pay a great deal of specific attention to data, because we're not necessarily providing clear data to people that they can use and apply. And right now, actually, it's just in the last 3 or 4 years that we in health literacy have turned our focused attention to math and to the presentation of data. With medicine, we have to offer fuller explanations. We have to conduct, for example, brown bag medicine checks. We can support an empowering relationship as a result of putting into play some of these sample strategies. Do the math is one of them. The average high school graduate in the US has difficulty with math. And once again, literacy researchers such as Apter, Peters, Anker, Sigmund Fisher, have really provided some wonderful guidelines for us. Just a couple to highlight here is that we should provide numeric information. Numbers do matter, but we have to reduce the cognitive effort required to use the numbers. So we have to provide meaning and context for numeric information. We have to draw attention to important information, and we have to set up appropriate systems to assist in review. For example, When something is online, we should never ask people to make a computation. We have the ability on online programs to do the math for someone automatically if they just put in the information or data that they have. This next chart helps us consider some of the difficulties. On one side of the chart, we have numeracy elements, and this is arranged in a hierarchical order of looking at what is easy, relatively easy for most people, including elders, and what is harder and harder as we move down. So simply reading numbers, counting, telling time, basic arithmetic operations such as adding and subtracting are relatively easy. Even there, when we get into multiplication or division, that's much more difficult for people. Looking at percentages is very, very hard for the average US adult who has difficulty computing a 15% tip, for example, in a restaurant. Reading tables and graphs are even more difficult tasks, and very difficult indeed is the ability to grapple with those broad concepts that require very sophisticated math skills, such as looking at risk, relative versus absolute risk, conditional risk, and so forth. Now, we also need to consider how people are going to use numbers. If they simply have to describe them, that's relatively easy. Let's go back to the slide again with the chart for those who are following the charts online. Describing is much more, it comes with greater ease than interpreting, which is much more difficult. And using numbers to make decisions is even more difficult. So what Andrea Apter points out in this chart is that the top part is the easiest and the part on the left of the chart. So we have to move up and move to the left when we're providing numeric information to people. Next, it's important to provide a context for data and not just a number. So we can't simply go along with the idea of knowing your numbers. We have to know our numbers, but know what they mean. So if you're given a number about, well, let's say blood platelet, that number has no meaning for a patient who doesn't conduct that kind of test. But if you put that number in a context, a simple context, that, for example, this is high or low, or this is where it fits within the range, a standard range, that's one step towards offering people an ability to evaluate the meaning of a number. If we go a little bit further and say, for example, well, this is outside of the normal range, but it's not worrisome. This is fairly common, and let's just watch it. And if we let people know what number is problematic and perhaps does cause concern and requires some action. So Siegmund Fischer does an excellent job on discussing how to provide a number in a meaningful way. There are different kinds of helpful displays. For examples, easy comparisons ought to be made for people in a visual way and not just with a number. On this slide, I use something from Siegmund Fischer where he's using an icon array, which has proven to be more helpful to people than simple bar charts or other kinds of charts where people can see actual figures. And when you can see a comparison, and here is a chart that's offered on cancer-free survival by treatment options, surgery versus radiation. You have both numbers at the bottom, but you also have a clear visualization. And this indeed is very helpful for people. The next thing that we need to do overall with our materials is apply scientific rigor in the development of our materials. And sadly, not enough of us are doing this. We have to provide a rigorous formative research at the base of any material that we're going to present so that we know what members of the intended audience need, what they respond to, and what they're able to understand. We have to follow guidelines that exist for the clear presentation of information. We must pilot test and revise with members of the intended audience and assess and revise existing tools. Again, sadly, few people are taking information as seriously as they take the scientific development of a vitamin pill, for example. We can't just concoct a material, a pill, and put it on the market. We have to follow very specific guidelines. And perhaps we need to bring that same mindset to information that we provide to people. Let me now proceed to the next area that we need to pay attention to, and that's the issue of tasks. What is it that we expect people to do? The proximal tasks are those tasks that people have to perform while using the text. And while literacy experts pay attention to this, we in the health fields have not paid enough attention to the fact that it's very difficult to locate information in a dense text unless it's highlighted in some way. That comparing and contrasting two different bits of information is a sophisticated task, that interpreting that information is very sophisticated. So indeed, to address proximal tasks, we have to make our materials simpler. Not simplistic, but simpler, by using all of the information that is available in guidebooks, highlighting main points, clarity, organizing, using headlines, and so forth. The distal tasks that one must perform after using the text, such as actually following the directions, calculating dosage, using the tools, monitoring and measuring documents, are indeed something that we have to look at, analyze, and ask ourselves, how can we make these tasks easier and reduce the cognitive load of these individual tasks? So that we have to engage in the activity that I call deconstruction. So we have to deconstruct health activities to understand the complexity. For example, we mistakenly think of screening as a task that you either do or don't do. However, getting screened for cervical cancer, for example, involves multiple steps, each of which contain multiple literacy-related activities, such as at first understanding and calculating your own risk to see if this activity relates to you, then reading and hearing about the availability of screening, determining if such services are available and affordable, finding those services, and so forth. So there are multiple tasks involved in getting screened. So we have to both simplify the proximal task, and I give an example on the slide here about forms, and this information has come from a Canadian study that looked at what older adults like about certain forms and what they truly dislike about others. And I'll just point out one of them as an example, that older adults have indicated real difficulty with using dependent questions. For example, questions that say, if yes, and then they have a little further question, and then they have an if no, and then they have further instructions or question. A lot of adults, including and especially older adults, feel compelled to answer both of them. So forms need to be simplified as well. An example of simplifying the distal tasks, how do we do that? We pilot test our instructions and have people who are members of the intended audience follow those instructions along with us, perhaps through cognitive interviews, and then we see indeed whether our instructions are simple to use or if there's room for confusion here so that we can revise those materials. Now let me turn to the issue of context. Context really refers to the environment within which activities take place. So here we have to examine the capacity of professionals and health institutions to provide accessible information and support access, the active engagement of people seeking care and services. We have to keep in mind that it's a complex environment that people are entering when they're entering a healthcare setting or a public health office or a program that has been set up for them. Healthcare settings are like foreign countries for many people who don't work within. For example, in a foreign land, we expect a different culture, and indeed we find a very different culture in a hospital, for example. The language people use, different from everyday language. The dress people engage in are different, and they have things around their necks and wear different color clothes. There are certain protocols and behaviors and expectations that we have, and there are sanctions for not going along with what's expected of us. And so we do have to bring about change. Change is difficult under any circumstances, but in order to understand the health literacy barriers that people face, we need to identify and minimize the emotional and physical distractors that are present in the environments. We have to consider the appropriate learning times and begin to identify and minimize constraints. And so this really impels us to look at policies, protocols, and regulations that could change the experience of people in healthcare institutions. We have to assess the environmental factors. Now, in 2012, the Institute of Medicine, now the National Academy of Medicine, called for health literate organizations. And I turned to some of my own work here. I introduced a mechanism for looking at a healthcare environment and identifying barriers that people face as they enter and walk about an institution. And we provided, first in 2007, a health literacy environmental tool that enables someone within an institution to measure and monitor the different aspects of their institution: policies, practices, navigation difficulties, culture and language, as well as communication. And we have a newly updated tool that we're labeling just by initials HLE2. And this relates again to the measuring the health literacy environment of hospitals and health centers. And this update was just recently completed with colleagues from the University of Tennessee Medical Center. It considers the health literacy environment, and I just want to give an example. For example, I mentioned that it considers communication, and there are ways that of considering institutional contracts for the development of forms, of test results, of response letters, instructions, directions, patient education, measures and trends. These are things that we need to pay attention to because it very much affects the experience of any adult entering that institution, and indeed can inadvertently erect barriers for an older adult seeking help. So again, I come back to the first diagram that I gave with the definition of health literacy. To achieve access to information, healthful action, disease prevention, and health services, we need to attend to each of these critical components, not just one of them. And it is the intersection of all of these where really helpful change can take place. To increase skills, to simplify text, to make sure that tasks are not arduous, and to make sure that the context within which people are working are open and freer and easier, where we've eliminated as many barriers that are possible. Now, I feel very energized by health literacy work because from a philosophic or political perspective, this is linked to social justice and health disparities. We need to consider not just health as a right, but literacy as a right. And from a practical perspective, and this really speaks to one of the appeals of health literacy work, this is malleable. We can really make change because literacy can be improved, communication skills can be improved, texts and processes. Change is possible. It's not reliant on some distant, large policy radical change in our society. These small steps really do make a difference. And so I claim that it's time for action. We have documented evidence about the limited literacy skills of adults and of older adults in particular. We know that literacy skills are linked to social factors and to health outcomes. We know that there's a mismatch between the reading level of most health materials and the average reading skills of US adults. And we know that health systems and healthcare processes have become increasingly and sometimes outrageously complex. There are implications for health disparities, but we can take action to remove barriers. We can do this by applying rigor to our practice, to the absolute insistence on scientific rigor as applied to health information, and we can advocate for policy change. So it's time for me to end, to leave room for questions. So again, I want to note that there are resources freely available. Here are just a few of them. Some of them are tools for developing materials as well as tools for testing materials. I want to point out two. Next, as a reminder, may I have the next slide shown? Oh, that this presentation is linked to opportunities for cancer prevention during older adulthood and will be followed by another webinar. Dawn, if I may ask you to step in and just make your announcement.
Absolutely. Thank you so much, Rima. The follow-up webinar to this will be held on Friday, August 2nd at noon Eastern Time. And in this presentation, I'll be sharing data from the National Health Interview Survey regarding the prevalence of sunburn and the use of sun protection among older adults. I'll also look at the associations between sun protection behaviors and sunburn outcomes and discuss the potential public health implications for skin cancer prevention efforts targeting older adults. And that presentation will be based on a paper that was published in that same supplemental issue of the Gerontologist. It's a fantastic issue. All of the articles are free to view, so I definitely encourage you all to go to the Gerontologist website and check out the other content in that supplement. And I hope you'll consider joining us for the follow-up webinar in August.
Great. Well, thank you for your attention.
Thank you, Rima. Just a reminder for everyone on the webinar that you can type and send questions using the questions feature in the dashboard. It's probably accessible on the right-hand side of your screen. We will not be using the raised hand feature today. So please, if you have a question, be sure to use that questions panel. And we are recording the session, so we will send everyone a link to access it by email once it is available, of course. Please, you will find, if you want to bookmark it now, all the details from this webinar at geron.org/webinar. So we'll give everyone a second to type in any questions they may have. Maybe while we give some time, actually there's one question here. What are some activities related to cancer prevention? For example, how do we highlight prevention to be more concrete? As prevention is such an abstract term, how do we communicate that with older adults to reduce cancer and risk, cancer risk?
Well, may I start? One of the things that we can do indeed is to build in issues related to cancer prevention into, for example, an office visit, and highlight the fact that the activities that people are engaging in, looking at a good diet, getting physical activity, using sunscreen, coming in for screening and so forth, it would be very important to highlight that indeed this is a cancer prevention activity, and congratulate people for engaging in this, what is considered an everyday or mundane activity, and point out to people that indeed these are cancer prevention activities that are very important to continue doing and to encourage others to do as well.
Terrific. A number of thank you messages, Rima. Thank you for a great presentation. And another question. Hello, Dr. Rudd. You have a slide that includes decision aids, and could you speak more about health literacy and decision aids?
Somewhat. Decision aids are constantly evolving. And this is a very, very important area that I'm really trying to pay focused attention to. I've noticed, for example, in a few overviews, that decision aids very often contain information that has not been carefully assessed for people. In other words, that we need to apply everything that we know about the tools, focused on vocabulary, focused on shared understanding of words and jargon terms at the very beginning, before that decision aid is even launched. People are very often loath to ask questions about meaning because they are loath to appear uneducated or ill-informed. So the impetus is on us to really do a very thorough assessment of anything that we're providing at the beginning of a decision aid. This includes math information, and I've been learning a great deal from the math experts that I mentioned earlier, Jessica Anker, Andrea Apter, Brian Zygmunt Fisher, about the presentation of data so that people are at a point where they can use the displays that are in front of them to talk, to make some decisions, to ask questions. So that, my experience is somewhat limited, but that's what I've been focusing on when I think about decision aids. And I wonder if I can ask any of the panelists, Dawn Holman or Mary White, for example, to add to that if they like.
Hi, this is Mary. No, I think you handled that question very well.
Good, I hope it was helpful.
Great, thank you. I have another question here. Rima, why has it been difficult to translate those many thousands of articles into practice?
I don't know. You know, I'm inspired always by Everett Rogers' work on the diffusion of innovation, you know, and trying to learn to be patient about this. Information from one field to another is a very difficult and arduous road to move, because we don't tend to read in other fields. So it really took a while for a lot of health people to recognize information that was coming out of the education field about literacy. So that's one. Second, we're very often focused in our own area of research. And if indeed health literacy has not become an important area in our work or in our own area of research, we perhaps may tend to overlook articles that relate to it. There are people who use the reason of time. Well, it takes too much time. I don't give respect to that reason anymore, because I really do feel that it's incumbent upon us to respect the issue of information as a critical tool that we must open up to people, and that we need to really place a great deal more time on this. Is it expensive? It could be expensive as far as pilot testing, but isn't it terribly expensive to develop materials and print those materials or go through the whole process of putting those materials, that information online, and have people not be able to use it or toss them in the trash bin. So it's hard to say, but I think that we have to more and more institute policies that make it incumbent upon not just individuals, but institutions, programs, agencies, to follow scientific protocol in the development of materials for the public. The
Great.
Plain Language Act has moved in this direction. It's helping us in government in slow but steady ways. So I remain hopeful.
Good. Thank you. Before we close the program today, are there any closing points you'd like to share with the audience?
For me, I know that I went through this very quickly. I just do want to highlight that we need to take special care when we're working with older adults. And as many of you may have seen, if you're looking at the slides, I'm one of them. There are issues that older adults are facing, and we need to be treated with care, but with dignity. And it's very important that we do pay attention to the issue that is clearly documented, that with less use as a result of perhaps in retirement, with less use of materials and math, perhaps because we're accustomed to the tasks that we do every day, we may lose some of our skills. When people are distracted by worry or concern or illness, they lose the ability to apply some of their skills. So everything that we do in our work with older adults, I think we need to think about how we're approaching our conversations, how we're approaching the development of our materials, so that we move ahead with an informed intent to help people access information that they can readily use and remove some of the barriers that might be in their way.
Wonderful. Rima, again, thank you so very much. It's been a real pleasure learning about considering health literacy for cancer prevention initiatives with older adults. And we thank everyone for participating. This is the end of the program.
Thank you for the opportunity.